Hey guys, Dr. Carmen Bryant here with NursingSchool911.net, and I'm back today with another video for y'all. And today is all about increased intracranial pressure. So we're going to talk some about the etiologies, kind of a simplified pathophysiology of increased ICP, and then some of the manifestations that you can expect. And then we're going to just go ahead and talk about the nursing care of these patients, which can be very complex. So increased ICP results in an increase in one of these three components, right? So a normal intracranial pressure, normal ICP ranges between 5 to 15. We consider ICP at a critically high level once it reaches 20 millimeters of mercury or higher. Okay, so that's a critical value that you guys need to remember for your exams. All right. So an increase in cerebral spinal fluid, an increase in blood volume, or an increase in brain volume. So some things that increase cerebral spinal fluid. I think of neurological infections such as meningitis, encephalitis. That's going to increase the production of cerebral spinal fluid and can increase ICP. Blood volume. So I think about obviously trauma, hematomas, hemorrhagic strokes, maybe. Anything that increases blood volume. We're actually going to talk about a very particular etiology that increases blood volume within the brain. But then finally, brain volume. So that's referring to cerebral edema. So ischemic strokes cause cerebral edema. Actually, 80% of the signs and symptoms that you see in patients with with ischemic strokes comes from cerebral edema. So, any of that cytotoxic edema when neurons die off, after strokes, or vasogenic edema. So any cerebral edema, an increase in that increases the brain volume. And that's called the Monroe-Kelly doctrine. So that just means that any increase in any one of these three components leads to an increase in ICP, okay? So our etiology today, we're going to be talking about respiratory acidosis, which is very common among our COPD patients, right? So we think about a respiratory acidosis, and with a respiratory acidosis, obviously CO2 levels are building up within the serum, okay? Well, CO2 or carbon dioxide is a very potent cerebral vasodilator, and it very readily crosses the blood-brain barrier. So what happens is with that respiratory acidosis, with that increase in CO2, it causes very potent cerebral vasodilation. Well, that opens up those cerebral vessels and allows for increase in cerebral blood flow. Okay, so this is an increase in blood volume. All right, so as that cerebral blood flow increases and the blood volume within the brain increases, then our ICP increases. But what decreases is our cerebral perfusion pressure. Okay, so as ICP goes up, space within the brain to be perfused goes down, and so cerebral perfusion pressure goes down. We like our cerebral perfusion pressure to be maintained at about 70 millimeters of mercury, all right? So cerebral perfusion pressure can actually be calculated by taking mean arterial pressure minus ICP. That will give you your cerebral perfusion pressure, okay? But just remember, as ICP goes up, CPP goes down. All right, so some of those signs and symptoms, you want to think about what are we going to see early on, okay? Because you as the nurse need to recognize those early signs and symptoms of increased ICP. So what do we think about? So we think about that restlessness, agitation, maybe reports of a headache, which is caused by pressure on the meninges from that increased ICP. We might think of things like vomiting without reports of nausea. That's caused by pressure on the medulla, which is the vomiting center. All right, so those are your early signs, okay? And those need to be caught early, right? Because if not, then they will progress to later signs, and those later signs are pretty ominous, kind of letting us know that, hey, this patient is in real danger of brain herniation, which is the absolute worst potential complication of increased ICP, right? So those late signs and symptoms, the most unique late manifestation of high ICP is something called Cushing triad. So what happens with Cushing triad is you're going to see an increase in systolic blood pressure, okay? And that's caused by the systemic vasoconstriction, which is trying to increase the blood pressure, so in response to, low cerebral perfusion, you have systemic vasoconstriction as a response to try to increase blood pressure and increase cerebral perfusion. So you're going to see an increase in systolic blood pressure without an increase in diastolic blood pressure. That's referred to as a widened pulse pressure, okay? You will see bradycardia, okay? And so bradycardia occurs actually as kind of a reflex response because of the increased systolic blood pressure. Those baroreceptors in the carotid arch, they sense pressure changes. And when they sense that systolic blood pressure goes up, they send signals to lower the heart rate. So you'll see increased systolic blood pressure, a widened pulse pressure because systolic pressure goes up, diastolic pressure does not. You'll see bradycardia and you'll see bradypnea, okay? So those are the three things that you'll see with Cushing triad. And like I said, that is ominous. And most often that lets us know that, hey, we've already got brain herniation that's occurring in this patient. So it's very ominous. Also, when you start to see fixed dilated pupils, when both pupils are fixed and dilated, that's an ominous sign of brain herniation. The most ominous signs of brain herniation are a very, very low respiratory rate and a very, very low heart rate. That tells us that the cerebellum, the brain stem, has actually herniated on down through the foramen magnum, which is the opening to the spinal cavity. All right. So when we start seeing that very, very low respiratory rate, very, very low heart rate, that lets us know that the brain stem that keeps us alive has herniated. Okay. And so that is a very, very late and pretty much irreversible sign that your patient has progressed to brain stem herniation. Some other things that you might look for: Doll's eyes, which that lets you know that there's brain stem impairment, that positive Doll's eyes reflex, and also a positive Babinski. That's never a good sign in an adult, right? That's where you kind of brush against the plantar surface of the foot and the toes fan out. That's a positive Babinski reflex, and that is not something that we want to see in our adult patient. All right, and so all these things will be tested on patients that have severe, significant, neurological impairment. We don't go around testing everybody for Babinski reflex and things like that. So those are the signs and symptoms that you want to monitor for early versus late of increased ICP of any cause. So this is, like I said, our traumatic brain injury patients, our patients with neurological infections, our patients with cerebral edema. So what are the interventions that we're going to, focus on, our assessments and our interventions? Obviously, ongoing neurological assessments. Pupillary responses are extremely important. So we're checking cranial nerves 2, 3, 4, and 6 when we're checking for consensual reaction to light and accommodation and pupillary size, and also extraocular movements. So we're checking pupillary reflexes because the pupillary reflexes are some of the first ones to go, when ICP increases. Some of the interventions obviously are going to be focused on getting that ICP down. Okay, so we're going to keep that head of the bed elevated to facilitate venous drainage from the skull. So at least 30 degrees. We're going to avoid head and neck flexion at all costs. So we're maintaining that head and neck in kind of a neutral position. That you might hear that word on an exam. Okay, we're not really going to be flexing at the hips or the knees or anything that could potentially worsen that increased ICP. We're going to limit suctioning if the patient is on the ventilator. Every time you thread that catheter down to suction, that induces like a cough reflex, which every time a patient coughs or sneezes or anything like that, that increases intracranial pressure. We're obviously going to maintain a proper acid-base balance, because remember again that CO2 is a very potent cerebral vasodilator. So CO2 being off or being very elevated is going to worsen increased ICP. Sometimes if we have a patient on the vent and we know that elevated CO2 levels, are contributing to that increased ICP, we might do what's called like therapeutic hyperventilation to help them blow off excess CO2 to hopefully get that CO2 down. We want to make sure that the patient is not febrile. So we're going to do antipyretics, because hyperpyrexia, increased body temperature, increases metabolic needs and metabolic demands. Any kind of shivering, we want to control that with sedatives. Anything that's increasing the metabolic need and the metabolic demands of the body, we've got to get that under control. We obviously want to make sure that we're monitoring eyes and O's very closely, right? Because with any neurological impairment, what are they at risk for? Diabetes insipidus, right? So any kind of increased ICP of any cause, we've got to watch eyes and O's, because we want to prevent yet another complication, right? So enteral nutrition, we want to make sure that we're feeding the patients. Restraints, restraints need to be a last resort, because pulling up and, being agitated and pulling up on restraints, obviously that increases ICP. Sedation and seizure prophylaxis. So with seizure prophylaxis, typically we're going to go with benzodiazepines like lorazepam, something like that. That would be like our first line treatment. Barbiturates, we might need to, actually induce a comatose state to further decrease those metabolic demands. If the patient becomes significantly hypotensive for whatever reason, we might have to do vasopressors to maintain that MAP and maintain cerebral perfusion. Sometimes we may be administering mannitol, which is an osmotic diuretic, if cerebral edema is the issue. One thing that we never, ever, ever do with anyone with possible or probable or suspected increased ICP is we never administer hypotonic saline. Okay, hypotonic saline causes cellular swelling. It causes fluid to flood into the cells, and that will absolutely worsen any cerebral edema that the patient has. Instead, we're going to do hypertonic solutions to help draw fluid out of the cells and into the intravascular space, and administer diuretics and things as needed to get that extra fluid off. Corticosteroids for any inflammation, especially if the issue is an infection, right? So treating the underlying cause is always key. But in that in-between time, before we can maybe pinpoint the underlying cause and get the exact treatment down, we're going to treat all those signs and symptoms and keep ICP as low as possible by performing all those interventions and assessments that we talked about in this video. So, there's also really more invasive measures like, you know, things that can be inserted straight into the white matter that continuously monitor ICP for us. And obviously, if those are in place, we're monitoring those for CSF leakage around the site of insertion and things like that. And those really help us to catch increased ICP early and treat it. Also, if your patient has any other hemodynamic monitoring in place, like a CVP, you know, if we can monitor CVP, then that could be really useful to let us know if hypo or hypervolemia, you know, may be contributing to a fluid volume overload or a fluid volume deficit, and we can treat that accordingly to that hemodynamic parameter. But that pretty well sums up ICP. Remember that ICP, or increased ICP, is considered critical once that level reaches 20 or higher. A normal ICP ranges from 5 to 15, okay? So remember the underlying etiology, the underlying pathophysiology behind it, and, you know, those key assessments and these assessments and interventions that we've talked about in the video. And I really hope that you guys have found this video helpful, and I just want to thank you guys so much for watching today, and hope you're having a good semester so far.